All right, well, thank you all for having me here. My name is Conor Steyer. I'm a medical oncologist at Emory University. And today I have a short amount of time to teach you about systemic therapies for head and neck cancer, both focusing on HPV positive patients, as well standard treatments, as well as some controversies or gray zones that we currently have in clinical practice. Just some disclosures. So this group will very well knows that head and neck cancer arises from several different areas of the head and neck. And each one of those areas has a different mainstay of treatment, although there's a significant overlap. Just in quick summary, to give an overview, oral cavity is typically treated with surgery, followed by adjuvant therapy as needed. Oral pharynx, the main topic of this talk, is chemoradiation versus TORS robotic surgery, plus minus adjuvant therapy. Larynx has a special issue of larynx preservation, so we often will consider CRT versus total laryngectomy. And nasopharynx is typically treated with chemotherapy with chemoradiation. And the standard chemotherapy we use is cisplatin, or platinum-based chemotherapy. So firstly, to start, some of the non-controversial data we have for locally advanced head and neck cancer was best summarized by this the famous meta-analysis examining a lot of patients. And in summary, what it showed is that when you add chemotherapy to radiation for locally advanced patients, it showed about an 8% 5-year survival benefit. Just pulled from the NCN. Our standard treatment, we use the cisplatin. There's debate whether Q3 week versus weekly dose is correct, but in essence, they're probably very similar, and you can use either. If they can't get cisplatin, other chemotherapies such as carbotaxol are an option, or cetuximab, which I'll get into. And the main topic of this conversation is, this is a TORS-based course, so it is HPV positive oropharynx disease. As you're probably well aware, it's usually caused by type 16 and 18 HPV virus. We usually refer to it in the sense of HPV positive base tongue or palatine tonsils. These patients are more likely to be younger, non-smokers, non-drinkers as compared to HPV negative patients. We often just use P16 as an easy IHC surrogate marker for HPV. And 75% of oral pharynx cancers are HPV related. And as mentioned before, the treatment for these cancers is locally advanced is either a combination of surgery, radiation, and chemotherapy. However, why is there controversy, especially in HPV positive disease? And because these patients overall tend to do very well with cure rates for locally advanced disease of around 80 to 90%, depending on various risk factors such as tobacco use. And these patients are often relatively young and healthy, and they live a long time post-treatment cured of their disease. And it is no secret that CRT, chemoradiation, has a lot of toxicity associated with it. Acute toxicities include mucositis, dysphagia, weight loss. I mean, you can see the list here, nephrotoxicity and such, which can lead to interruptions in their treatment and some potential secondary long-term issues such as xerostomia or swallowing issues or taste changes. So the answer is, since these patients do so well and there is toxicity associated with the care of these patients, can we maintain this efficacy we're seeing while decreasing toxicity or de-escalation? Just some mucositis pictures that I pulled off the internet, but it's basically typical of any patient you can see going through CRT, and I've seen some pretty bad ones in my clinic. And as we get to de-escalation, one thing that's important to remember is that not all HPV positive oropharynx cancers are equal, and some are high risk and some are low risk. So when you're thinking about what, if we get to the point where we're just stratifying, what patients we should de-escalate, you have to keep this in mind. So going back to some, how we got where we are, this is called the Bonner trial. It was before platinum-based chemo was the standard, and it was looking at the treatment of head and neck cancer with either radiation alone or radiation plus cetuximab, an anti-EGFR antibody. And what they showed in the green line here is that adding cetuximab increased overall survival, and it became a standard of care. Remember, this was not compared to platinum chemo, it was just compared to radiation alone. So this led to the definitive RTOG 1016 de-escalation trial, taking patients with HPV positive oropharynx cancer and undergo chemoradiation in the definitive setting to either big dose cisplatin every 3 weeks or cetuximab, thought to be less toxic. And they enrolled a big study, non-inferiority study, and they enrolled 850 patients with the main endpoint of being overall survival. They were well balanced between the groups. And surprisingly, some results they showed were one, just to kind of summarize this page, is that the toxicity levels were not particularly different between the groups. They were different. Cisplatin causes decreased blood counts, nausea, vomiting, kidney injury, and such, while cetuximab causes a lot of nasty rash and allergic reactions. So similar toxicity between the groups. And importantly, what they showed is that the study and primary endpoint, the cetuximab did not meet the non-inferiority criteria and actually had a worse overall 5-year overall survival with 78% versus 85% in the cisplatin group. And this is just that same graph, the same information just shown in graph form, with the blue being the addition of cetuximab, with red being, blue being cisplatin, with the red being cetuximab. This led to, concurrently was the De-ESCALATE Trial, which was a randomized phase 3 control trial in Europe, and basically its primary endpoint was toxicity at 2 years. Same thing, low risk, this one had low risk, but HPV positive oropharynx cancer. And again, their primary endpoint, toxicity does not differ, same thing as 1016, similar quality of life. And they showed a worse overall survival, with 2-year overall survival for cisplatin being 98% and 89% for cetuximab. I like how they phrase it here, with 1 extra death at 2 years for every 12 patients treated. So just to kind of quickly summarize in the definitive settings, cetuximab was inferior to cisplatin in any criteria you can manage. If a patient is not cisplatin eligible, consider other chemo, and if not, and you still want to give them something, consider cetuximab, as it is better than radiation alone. Not sure how this relates to HPV negative disease, but probably holds true. And de-escalation is a worthy goal for HPV positive oropharynx cancer, but these studies should be performed thoughtfully and carefully. Next, I want to move to what if in the adjuvant setting, what do we do? So this is a TORS procedure, which, given that's the primary point of this course, you're all familiar with. This is Dr. Patel, one of my colleagues, doing a TORS surgery. So what do we do after, just in general, for head and neck? We add cisplatin. How do we do what we do? This study was actually 2 studies combined, looking at the addition of cisplatin to radiation versus radiation alone after surgery for head and neck cancer. They found overall no statistically significant survival benefit for the addition of chemo, but when they looked at a 10-year follow-up, just extracapsular extension or positive margins, they did find statistically significant survival benefit. So that's why our, in general, standard of care is, if patients have extracapsular extension or positive margins following surgery, we do offer chemotherapy with their radiation. As of late, that also includes if they have 5 lymph nodes or greater. But HPV patients post-TORS resection do really well. Do they need that extra toxicity of chemotherapy, radiation, the doses given, or is the data applicable to HPV positive oropharynx cancer? Does the amount of VCS matter? Do margin size matter? And E3311, I'm sure you're all familiar with, was examining intermediate risk patients. Do they need the addition of the radiation dose, 50 versus 60 gray. And what they found is the intermediate arm without chemotherapy, which included less than 1 millimeter extracapsular extension, patients did really well. And only a phase 2 study, but did show that de-escalation could work in this setting. And there is some single institution data looking that ECS is not an important prognostic factor for HPV positive head and neck cancer. So just to finish up in my short amount of time, I just want to first just touch on immunotherapy. It's been around for a while now, so I'm not sure how familiar you are with it, but immunotherapy, in the context that we usually mention it, typically is discussing about PD-L1 or checkpoint blockade inhibitors. The PD-1 pathway is a negative impact on the immune system, basically to shut it down, and cancer cells can co-opt this and turn off basically our immune system to attack the cancer. And at this point now, there's dozens of indications for these checkpoint inhibitors, such as Pembrolizumab or nivolumab, in the treatment of cancer. And immunotherapy in head and neck cancer, just in short, Keynote 048 is our latest standard of care, and why we use immunotherapy in the frontline setting. It was compared to Pembrolizumab versus the kind of big toxic extreme regimen, platinum-based cetuximab chemo, and showed increased survival benefit. Now there's some nuance based on how strongly they stain for PD-L1 on what you choose, whether it's immunotherapy or immunotherapy with chemotherapy, but that's the general idea. However, and so obviously we want to try to move it up to earlier stage disease like we do in lung cancer, but we have to be somewhat cautious. The Javelin 100 study was a negative study using avelumab for chemoradiation with locally advanced head and neck cancer. And there's many ongoing investigations of immunotherapy for locally advanced head and neck cancer, and lots of questions are being investigated and need to be answered. Timing of the immunotherapy in terms of their chemo, radiation, or surgery, HPV positive versus HPV negative in terms of immunotherapy. Do you give it with radiation or surgery? High risk patients versus low risk patients, who benefits more? Can it be used preventative cases like high grade dysplasia in the oral cavity? Can immunotherapy benefit them? So just to finish up, so for me, prospective data is needed in order to change practice. I'm always weary of retrospective single institution studies, i.e. this cetuximab de-escalation trials prove that. I think the standard of care right now, although some of gray zone for HPV positive patients that undergo TORS with ECS greater than 2 millimeters, I think you should give adjuvant chemoradiation. I think it's preferred. I think most people would probably agree with that, although I can't speak for everyone. I think greater than 5 lymph nodes should definitely get platinum-based adjuvant chemotherapy. For patients with less than 2 millimeters of ECS, I think this requires a discussion with the patient and other caregivers in the patient's care, discussing pros and cons. I tend to favor CRT for good PS patients from 1 to 2 millimeters, but this is very much an area of active investigation and controversy. Something recently is our larger, that 5 millimeter margins, what we classically use for kind of big HPV negative tumors, are those same margins. Well, I should say those large margins are probably not necessary for HPV positive oropharynx cancers to decide if chemo is needed and more investigation is needed. And then the role of immunotherapy is to be determined. And that concludes my talk. Thank you very much, and I hope you enjoyed.